allocentric, reframing surgery through allostasis and neural network models. So just to say, we like to pay tribute to Indigenous peoples. The Native American Service and Equity Group, they did a lot of advocacy efforts in 2022, and we were able to actually get the University of Arizona to have a formal land acknowledgement. So this is to the tribute. So we respectfully acknowledge that the University of Arizona is on the land and territories of Indigenous people. Today, Arizona is home to 22 federally recognized tribes, with Phoenix being home to the Action Indian community, Fort McDowell Yavapai Nation, Gila River Indian community, and Salt River Pima Maricopa Indian community. We are committed to diversity and inclusion, and the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education, offerings, partnerships, and community service. Okay. So why a new paradigm from egocentric to allocentric? So to break down the root cause of these words, so egocentric, ego meaning self, centric meaning centered. When we talk about surgery, it's often in this egocentric kind of way of where it's all about the surgeon and the technique and the precision, and to optimize patient outcomes, the technique needs to be the best, and the precision and the surgeon needs to be the main kind of part in the whole situation. And for allocentric, the root allo is other and centric being centered. So instead of self-centered, this is more other-centered. So it's pretty much connecting surgery in terms of all the different contexts in which it can arise, and whether that's physiology, whether that's the patient's emotions, their social context, their environment. And allostasis is kind of the dynamic adaptation across all of these systems. And so allocentric is not a word currently used in the literature, but I thought it was a good way to represent this kind of new paradigm shift from egocentric to allocentric surgery. So just to break down allostasis versus homeostasis, so Dr. Peter Sterling in 1984 initially started this concept, and it was this idea that instead of homeostasis, which is stability through constancy, allostasis is the stability through change. So what we all know is that the only thing that is constant in this world is change. Everything is changing around us, things are changing inside of us, and our brains are this mechanism in which we're able to adapt to this change and consequently anticipate what needs to happen in order to better optimize our life, our reproducible nature. And this is one of the quotes I really liked by Dr. Sherling in his readapted paper in 2021, that allostasis proposes that efficient regulation requires anticipating needs and preparing satisfy them before they arise. So this is this kind of constant model that the brain is anticipating what needs to happen, and we are having some interactions with that every day. So just because some people are on their phone, this image on the right, it shows this kind of easy example of allostasis is blood pressure, right? We kind of know that high blood pressure is associated with a lot of negative health outcomes like heart attacks, strokes, and a wealth of other possible medical pathologies. And so what this idea is that the allostasis is that blood pressure is related to all these different mechanisms. So one huge one that we talk about is cortisol, right? So cortisol, when we feel stressed, our body likes to adapt to that stress by increasing your heart rate, which increases blood pressure. And in another way, we also have things like vasopressin, which we know that is related to anger. And so when we're really angry, our blood pressure also shoots up. And we've kind of found that, has anyone, when sometimes you're feeling like really sad, or, you're feeling stressed, you tend to like eat more salty foods. This is kind of one of the things is in relation to that, is when we're feeling stressed, our body has this high blood pressure, and we end up eating salty foods by pretty much they're like electrolytes, and it increases the amount of like volume that's going through our blood to handle that blood pressure. And so this kind of idea is that the brain is constantly adapting to all of these different mechanisms of this like blood pressure. So over time, your body is anticipating that you're going to be in stress if you're kind of stressed all the time, and your body's going to kind of stay in this consistent high blood pressure state, which is kind of not conducive to kind of healthy living and healthy mind-body connection. And this other picture on the right is just another kind of mechanism to show that how the immune system is involved. So, let's say we get sick, our body wants to attack that infectious agent with our immune system. So we kind of increase our kind of metabolic activity to increase our temperature. So that's why we get a fever. And we inhibit these like inflammation kind of structures that are in place when we're stressed out. So when we feel stressed, sometimes we get sick afterwards when we feel really stressed. This is kind of one of those mechanisms in which we kind of see that there's all these multiple avenues that where if we're feeling really, or like if we're having a high arousal, or maybe we're in high stress, that could suppress the immune system, which could lead us to getting more sick. And these are images derived by Dr. Sterling and Ayer's original paper in 1984. So allostatic load, this is kind of a really important principle. So what kind of happens is we're always adapting, constantly adapting in all these different situations that we have in life, right? So let's say we have this perceived threat. We have this behavioral response where we're going to go either, fight or flight. Let's say we have this stress. Okay, I'm going to start eating. I'm going to maybe smoke or all these different things. And our body is kind of taking score of all of these different levels of ways that we're adapting to stress. And over time, as you can kind of see in the diagram on the right, we have this stressful event, we recover. But when we keep having these stressful events and we are not able to recover from them, we kind of increase something we call allostatic load, which is just a principle stating that over time, our baseline stress levels get higher, and over time we have this load that is kind of impending on a lot of the ways that our body normally handles a lot of our functions in our body. So this is kind of a easy kind of way to think about it sometimes is, so allostasis is this, you're having stressors and you adapt, and the seesaw is like, it's fun, you're able to kind of go in the balance of the seesaw. But an allostatic load is when you kind of go beyond that and you start having all these stressors. So your body starts having to adapt to all these stressors, which could be, high blood pressure. Also, in response to stress, our body releases sugar, so it can lead to high sugar levels, and multiple other avenues to where this allostatic load can have negative effects on our body. And so allostatic orchestration is a concept by Dr. Lee that was in 2019, which kind of means that all of these relations are happening to the brain, and the brain is also having kind of input on the rest of the body. So it's this bidirectional mechanism where, as you can see on the right, is where when you're able to be in this mechanism where you're being more adaptable, right? You're less rigid, you're able to be more flexible, then over time you start being able to handle more difficult or any types of situations, right? So it's kind of the idea is like every time you're just going with the flow, you're actually changing the mechanisms in your brain to better anticipate stress, adverse experiences. And this is not just like only like, oh, just stress, like even in good things, like if you're let's say like in surgery, for example, is like if you're constantly being able to adapt to what the next obstacle could be, then you could be in this better state where you're able to anticipate, if this happens and this happens, and like what do I need to do? And it's this flexible interaction with our changing environment that allows us to have this flexibility in our neural dynamics and our neural chemistry to be able to handle more kind of experiences as we continue throughout our life. Another theory that I want to talk about is called the polyvagal theory. So we've all kind of heard of maybe the vagus nerve, and it's something that we've kind of known as like, oh, it calms us down. When the vagus nerve is stimulated, you get like a decreased heart rate, decreased blood pressure, and it's kind of known just for us to kind of calm down. And the way that it approaches this level of kind of calming down or not is based on threats that we have internally, our relationship with others, and how we're interacting with our environment. So constantly. And in this polyvagal theory model, it's not just that, oh, you have this vagus nerve that's always calming us down. And, through scientific research and a lot of like neurobiological studies, we found that you have this kind of ladder up version of the autonomic nervous system where you have this dorsal vagal activation, which is where you just feel like, it's like fight or flight or freeze. Freeze is when your dorsal vagal is turned on. You don't feel scared. You feel like you can't go do anything. You just want to hide under your bed. You feel collapsed. The world is empty, dead, and dark. And then it kind of goes up to this other level of like sympathetic activation where it's a lot about like, I'm feeling anxious, I'm getting overwhelmed, the world seems dangerous. And then you have this ventral vagal activation where you're feeling like safe and, I'm feeling at ease. I can manage whatever comes my way. I feel empowered and connected. And what we've seen is that when we have this ventral vagal activation, when we feel calm and safe in our environment, we allow ourselves to be more adaptable. We allow ourselves to have this, allostatic kind of flavor that allows us to be able to continue to like work and adapt to whatever situations that we're um, being confronted with. And so next, I want to talk about the triple network model. If anyone has any questions on this, please, let's talk later. I love talking about this. So there's kind of broken down into kind of three things. So you have this default mode network, which is this area. So in our brain, when we're resting, our brain's always active, whether we're, just doing nothing or doing something, our brain's always active. And whenever we're, the mind wandering or we're thinking about things, we're ruminating, we're in this default mode network. Our brain is these certain signals are turned on, and that's how we're processing information. And then you have something called the central executive network, and that's when you're doing a goal-directed task. You're getting up to go do something. You're actively engaging in a task. And then this salience network, which is kind of this middle area of between like when you're not when you're not doing something and then the area of doing something. And it's kind of like a switch that allows to go one from the other. And now I'm just going to kind of talk about some more examples of that and how we can use it in our daily life. So, all right, let's say you're on the couch, you're just thinking about life and everything like that else you got going on. And then you're like, I want to microwave some popcorn. And you're like, okay. And then you start thinking about microwaving popcorn. You're like, oh, do I do this? Do I not do this? And then you kind of you weigh the level of importance that this popcorn is to you. And that is kind of this middle gray area of like your salience network. It's like, okay, I'm feeling aware. I'm thinking about myself, thinking about me doing like wanting to eat popcorn. Do I do this activity? And they're like, okay, yes, I'm hungry. That is important to me. I will make this popcorn. Then you kind of transition into this central executive network. And just, this can be when you're also just ruminating and you start realizing, oh, you're on your phone and you get into this kind of, you're in this deep scrolling of social media. Sometimes it's harder. You've kind of noticed maybe that's like harder to get up and go do a task like after, you do a lot of this like social media or you're kind of doing something that is a lot of like self-ruminating thinking. And we start realizing that for us in terms of like, let's say we're thinking about being lazy, us even just thinking about being lazy kind of reinforces this default mode network and our beliefs and our core values that make that up. And what and is in reality is that but all of these networks are kind of in tune together. They're constantly working with each other. And this salience network is constantly seeing like, okay, what is important to me? What is something new, like what is going to make me get into the central executive network. And also in the vice versa, right? You have sometimes where you're very OCD, you're like, oh, I got to get all these things done. And it's like, wow, maybe I just need to sit and just, just breathe and kind of go back to just, thinking about things. And um, we see in depression, in like images of people's brains function, that when people are really depressed, they have this default mode network really active. So you'll start seeing that, oh, I'm really sad. I can't do anything. I'm just ruminating and I don't want to go do anything. And for anxiety, for example, your salience network is really hyperactive. You're like, oh wow, this small thing, like, oh my cat is not being happy right now. I don't know why. And you start thinking about it and you're like, okay, I need to do this. And your salience network starts becoming super hyperactive to like novel new signals, and that can also be negative. And in addiction, you can also see like this like hypoactive of salience network where, you take a drug, you start feeling really good, and then your receptors are like, oh, I want this more. So like the level of novelty that this drug had starts kind of fading, and that's kind of where the tolerance kind of comes into picture. So big goal here, salience optimization, mindful, right? So in the depression, one of the goals of depression is decreasing the default mode. And we can do that by gratitude journaling, compassion practices, things that are kind of reinforcing positive things in our default mode that allow us to continually like want to move like through to the salience network, to the central executive network. And then for the salience network, it's like, okay, well, how do I tune myself into thinking that things are novel? It's like, okay, like, things that we kind of already know. It's like maybe I go out on a walk, maybe that's going to help, maybe just seeing something new, maybe thinking about something new, trying a new activity. And we start realizing with anxiety as well, this hyperactive salience network, if we start, maybe taking a step back, doing mindfulness meditation, just kind of being aware of things that are kind of going on around you, and that is allows us to kind of be better in control of how our salience network is kind of firing in terms of our anxiety. And for addiction, our salience network is pretty much hijacked, right? We have to be able to reorient our salience network, and we can do by these things called like urge surfing, which is like mindfulness, where you like allow the experience of the craving to come, and then and then you just don't do anything with it, right? And you're kind of tuning your salience network to better orient itself to these different drugs or signals that are allowing ourselves to be in these same networks. Okay, and so now I'm going to go actually into the surgery part. So the framework for allocentric approach to surgery, we're going to talk as allostasis, triple network model, and polyvagal theory. So this all starts, I'm going to break it down into preoperative, intraoperative, and postoperative. So preoperative, this all starts in the first patient encounter, right? It's something called therapeutic presence. In polyvagal theory, it's where the provider makes a patient feel safe, right? And we know that once this kind of relationship is built, we get something called heart rate synchronicity, where our heart rates start kind of being in line with each other, our respirations start being in line with each other. And we know that this increased physiological safety, we know that that's going to decrease our cortisol, and we know that that also is going to improve our healing. And we've known through a lot of various studies that compassion-based interventions focusing on just communication and emotional support decrease perioperative anxiety and depression. We also have this feelings of Jong. Dr. Lee says this in his 2024 paper a lot, and it's this feeling of connectivity that we have with other people. It amplifies our endogenous opioids, which makes us our feeling of being happy and feeling connected and purposeful. So just by just being there with the patient and kind of having this as a very big goal of this therapeutic presence is going to start improving patient outcomes, I think, from the very beginning. And so these are just some things to take away, right? Sometimes it's hard to be like, okay, well, someone's telling me something very deep, and I don't really know like how to exactly handle it. And here are just some things that, you can do, like a soft gaze, maybe a gentle touch at the right time, slow exhaling, and our pitch and our rhythm of our voice, eye contact, like all these things able us to have better therapeutic presence with the people that we're with, whether that's a patient, your friend, your family. And by doing that, it kind of increases their level of like ventral vagal tone. It helps improve outcomes. It's overall just, better for everybody. And these are just good cues that you can take in your everyday life. Okay, so this is also one of the big things. I don't know if anyone's been around people that have surgery or not. Um, but before surgery, people get kind of put into this preoperative holding area before they get into surgery. It's a very like anxious time, it's very like, yeah, I'm about to have surgery. I don't really know what's going on. All these people are coming in, poking and prodding me. And what I'm proposing is that during this uh, pre-operative phase, we start incorporating some level of like mindfulness and breath work, right? And this actually starts even when we have that first appointment with them. We introduce them to this certain mindfulness strategy and meditation strategy, and kind of that by that, it starts decreasing their anxiety, decreasing their arousal level. And we know this is also work done by Dr. Shirley in 1984, that when we have all of this decreased arousal or feeling calm, we have better blood flow to the kidneys, the skin, the gut. We have better repair and growth of bone, replacement of cells with high turnover, production of cells for our immune system, like all of these things that are so positive that we know that is working so beneficially on a physiological level for wound care, for surgery optimization, that by just, maybe even incorporating these levels of mindfulness, it's not just decreasing their anxiety at that time, but leaving these long lasting impressions. And it also starts this salience network programming where it's like, okay, this is something where I can kind of get out of my default mode of being anxious about this procedure and start tuning in to myself and to be able to better kind of handle that when that actual comes. And it kind of demonstrates that importance earlier on. So some things that we know, so one of the things that people have investigated and found out is that if you're anxious before surgery, that's gonna potentially increase your postoperative pain, decrease your sleep, increase your opioid usage, increase your risk for complications, and increase your hospital stay, which no one wants, right? And so some interventions are already happening that already came into place to kind of help this. Is aromatherapy has been used to help preoperative anxiety. Guided imagery relaxation therapy has known to actually decrease blood cortisol levels in the preoperative period. And one of my favorites is like listening to patient preferred music preoperatively can reduce anxiety. And whatever type of music you want to listen to it that makes you feel good and calm. I think we should telling that patient in the beginning, being like, hey, you should bring your headphones or earphones and have a nice playlist picked out, and so you can kind of feel calm too. And then we're also kind of redoing those meditations and kind of strategies that we had in the beginning encounter to also this current encounter right before surgery. Okay, and so the intraoperative, the timeout ritual explained. So before, this has kind of been standard in the last maybe like 10, 20 years. Before, once the patient is on the operating table, it's called a timeout. So everyone times out. Everyone usually kind of listens to whether it's the surgeon or the nurse, and they say, this is the patient, this is the side we're operating on, here are the risks of the operation, here's the name of the patient, so it kind of decreases this, kind of keeps like a checklist of all the things that need to happen in order to kind of optimize surgery. And that's actually been well established. That has been super helpful in like decreasing complications and minor errors as well. And we know that a lot of times with burnout, whether in surgery or others, it's can a lot of times be due to depersonalization and compassion fatigue. It's like, yes, you're a doctor, you're helping people, that should be enough. Well, it's like, no, like sometimes you start, depersonalizing, your compassion starts getting lower. And so we actually have an ongoing randomized control trial at Dignity Health that I'm leading with Dr. Ross Bremner. It's been the last 3 years. We've had 50 patients randomized, and we're calling it a compassionate timeout. So right before the surgeon, right when the surgeon meets the patient in the preoperative holding area, the surgeon actually brings the whole team together, whether it's like the anesthesiologist, the nurse, and it brings the whole team together and be like, hey, this is Sung, your anesthesiologist. This is Nikki, your circulator nurse. And it helps, and it kind of just personalizes the patient to the procedure, to the team, and it allows the surgical staff to feel more kind of in tune with the procedure, in tune with the patient, fosters this teamwork and Jong. And so we have like 10 more patients left, but overall the preliminary results have been positive. Surgical staff think that it's not a huge waste of time, which was our main concern. And the patients think, it helps satisfaction, it's helped increasing compassion and wanting to be with the surgeon team more longer out. So this is kind of something that's already in the works and kind of related to a lot of this stuff, but more work definitely can be done. Okay, so yeah, and also just intraoperatively, the team dynamics as allostatic regulation, have a picture, keep calm, teamwork makes the dream work. The OR is not just the surgeon, it's a collective body of anesthesiologists and circulators and techs and everyone needs to be on their optimal like salience network optimization, right? Everyone needs to be able to take in whatever information comes and be calm enough to react to it in a calm, reactive way. And when you, as a surgeon, as a leader, sometimes it's important to all the time to empower your team, make sure they feel calm. I can't tell you how many times like the surgeon's been all like kind of like mean, and then no one wants to communicate to them that there's problems happening because it's like they feel scared that if they speak up, like maybe that's going to negatively impact me. So they rather not say anything. So this, starts really with the team. It's it has to do with a lot with like dynamic relationships and how they're changing and constantly being aware of them and being in tune with them to better optimize patient care and operative sequencing as well. And also, this all correlates to the triple network model too, right? If we have this switch that's constantly is being able to be adaptable, we allow this default mode, which could be just our anticipation of things, our thinking about what could be next. And okay, our switch is optimized, we can immediately turn that into a goal-directed task, right? And so this is something that can be related to all levels of medicine and non-medicine. So post-operative. So one of the kind of fields of interest that I'm interested in is thoracic surgery, which is lung surgery. So a lot of times we're removing parts of the lung due to most of the time due to cancer. And one of the things that we tell people to do is like breathe into this tube, and it helps them like expand their lungs. It helps reduce coughing, helps expand their lung or reduce hospitalization, reduce pneumonia. And so it's a pretty standard care. We tell people to do it 10 times an hour. It's very hard to get people to do it. And so one of the kind of proposals that I wanted to kind of start was reframing this kind of mindless like toy that we have to breathe into a mindful breathwork practice. So it's like this same mindfulness and meditation strategies that we learned in the beginning that was there for preoperatively, it still continues postoperatively. And we use this kind of incentive spirometer to make it more of like an intentional task, right? And it doesn't just enhance the technique with slow, deep breaths, but it also helps reduce anxiety, right? Who like big, deep breaths, calming down, calms the vagus nerve. And these are all things that we know that anxiety post-operatively can lead to all these kind of negative outcomes. So extends these preoperative practices, improves compliance, and also the same thing with the triple network model, it increases motivation and better able to actually do the task like, okay, I need to do this incentive spirometry. And it kind of allows yourself to be more adaptable instead of being like, oh, I don't have to do this. Nobody's telling me that I have to do it. But if we kind of make it as like, oh, this is going to help you in every single which way, and the surgeon tells you to do it, it's like, okay, maybe I'll try it. So this is kind of like more big kind of ways that we can be incorporated into something that's already there. So post-operative, preventing complications through stress and pain reduction. We know that stress exacerbates immune dysregulation, makes people more sick. Let's work on that, right? Let's help manage that preoperatively, intraoperatively, postoperatively, and to better have people to have patients that heal better from surgery over time. And one of the big things we worry about in thoracic surgery, since we're really near the heart, is atrial fibrillation, which is when your heart is kind of beating in the same rhythm that it's really not supposed to. And that can lead to like clots, and that can go up to the brain or the legs. Not Definitely not a good thing. And we know that stress relates to that, right? So this is definitely something that if we start having this stress is a huge kind of way for us to look at how to optimize patient outcomes, I think that would be very positive. And this is something that is already talked about in concession statements that people that, are on a lot of, let's say, opioids, like we want to be able to use mindfulness-based training as adjuncts to the medications that they're already on. So for stress and pain, an allostatic approach would be, not just multimodal pain regimen. Multimodal being you don't just give people opioids, you give people maybe a little bit of opioids, maybe a little bit of like ibuprofen, maybe give them like a nerve block. And it's just kind of this multimodal kind of pain. Also, mindfulness stress reduction, which we've talked about. And allostatic also means patient education, being able to talk to them, communicate with them, shared decision making, let them have some central executive network kind of uh, motivation to be able to be like, hey, I'm a part of this. I want to also be incorporated with this. And that's going to help them feel like they can heal better. And placebo effect, but the placebo effect is a real thing, right? It's happening on a neurological level that could be the exact same as something that's not placebo. So placebo is great sometimes. And we're dynamically adjusting. It's not like, oh, we're gonna stick to this one thing and this is exactly it. It's an ongoing assessment of pain, psychological status, and seeing if we need to adjust meds, maybe give more mindfulness therapy, maybe have their family come over at like non-visiting hours. Like it's all these different kind of levels and ways to kind of approach it. So almost done. So allostatic load and recovery and discharge planning. Pretty much we know we've actually been able to kind of uh, quantify a little bit of allostatic load in terms of like heart rate and blood pressure and BMI, blood glucose, things like that. And we've known, and we kind of know now that for patients with allostatic load and a social vulnerability index, which is pretty much people that have a lot of different social determinants of health, for people that have colorectal cancer, we know that allostatic load increases postoperative complications, extended length of stay, and even mortality within 30 days. So this discharge, when you're discharging a patient, it requires awareness of all these kind of different mechanisms that are contributing to their health. And it's just recognizing it, right? We can't fix it, fix it all, right? I can't just move someone to a whole different zip code, give them $1 million and tell them, hey, this is how you're going to get rid of all your anxiety. It's like, no, maybe we can't do that, but maybe there's different ways that we can address it. Like maybe if they don't have a support system, we give them cancer survivorship programs. Let's say they're in a rural setting and they have a hard time getting their medications, maybe just, coordinating their medications here in town before they leave from the hospital so they don't have to worry about it rurally. And this kind of continues into post-op appointments with this therapeutic presence. Healing is nonlinear. And, if someone is, let's say, like still in pain or still kind of feeling this operation of surgery, you don't just go hands off, well, the surgery went okay. This is like it's a constant level of adjustment and dynamic management of the patient's health after too. And, utilizing resources that a lot of hospitals do have in terms of like transportation, housing, food, behavioral health, and kind of knowing these resources as a clinician to better help patients long term. So kind of last kind of remarks. So implementation and future directions. This, as we talked about, is a very like socially dynamic situation. And so having workshops for staff, making staff know about this allocentric approach, this therapeutic presence, allows them to be able to kind of better contribute to the big plan, which is like hopefully just optimizing patient outcomes and increasing more peace into their life, and the patient's life. And we're integrating this with existing tools like the timeout and the sensitive spirometry, and we're repurposing them. We have research going on right now, but kind of continuing this research, expanding trials, standardizing the meditation strategies, using evidence-based principles. And a lot of this is about empowerment, right? We're taking ownership of that time, that space between, do I want to get popcorn or do I want to sit here on the couch, right? And by really kind of starting to take ownership of our own salience network, we're able to better adapt to anything that life throws at us and be able to move within life through with creativity and flow and just overall joy. And just long term, we start presenting this research, we start little pilot programs, and then, down the road, you get, maybe allocentric surgery centers that are all surgery centers are all kind of focused on this allocentric model. So last kind of conclusions, surgery must evolve from egocentric to allocentric. It's not just technical mastery, but collective regulation of patient, team, and system. All of these kind of things we've talked about of allostasis, polyvagal theory, and triple network models provide the framework for this. And practical interventions show this isn't a trap. We've done studies, other people are doing studies. It's implementable now. It isn't something that we have to do like so long in the future. And the vision is an allocentric surgical practice that heals not just with the scalpel, but through regulation, connection, and shared humanity. Okay, yeah, that's it. Thank you. Thank you so much, everyone, for coming.
Yeah.
Did you
Thank
just evolve a new term, allocentric? Is this an evolution here?
It's so funny because I mentioned it to Dr. Sung or Dr. Lee one day, and he was like, did you make that up? And I'm like, I thought you told me that. And I was like, and I was like, oh, he's like, no, I never said that word. And I'm like, oh, okay, I guess we're going with it. Um,
Beautiful.
yeah, it's
Love it.
not used in the literature too much, but yeah, I think it kind of incorporated a lot of what we're talking about. So yeah.
Lovely. Beautiful. Wow, this is such a hopeful talk. My anxiety about whatever surgery is pending for me in my life is down already.
Good. Yes, we love that.
Where were you at the Mass General when I needed you last year?
I know. Hopefully in the future. Well, hopefully in the future.
Yeah, no, this is really terrific. Yeah, I couldn't. It's so interesting that, you've taken this in many directions that I would not have imagined. Don't know anything about.